Hello, this is Dr. Lauterbach, and this is the Week 12 mini lecture. In this lecture, we will cover chapters 20 and 21. Chapter 20 is about LGBTQ health. From the evidence that we know and how to apply that for the promotion of health among the LGBTQ community. Members of the LGBTQ plus community have been marginalized for really forever in Western society, but really it's been fairly recent that we have data to help us in crafting interventions that are of help to this community, largely because until pretty recently, the instruments, the health surveillance instruments, excluded questions about sexual orientation and gender identity. It was in 2020, the Healthy People 2020, that LGBTQ plus health disparity reduction goals were outlined for the first time. The health risks specific to this segment of the population arise largely out of societal stigma. The climate is hostile, there's ignorance, and the community is often treated invisibly as though they don't really exist or don't have a major impact or contribution to society at large. So that drives experiences of discrimination, violence, and microaggressions. The authors contend that there is an overall lack of awareness about LGBTQ health issues among nurses, and that the education of nurses has done a really poor job in terms of covering this. And I think up until very recently, that certainly has been true. We are trying to make efforts to expand the knowledge of specific health needs and risks of this population in our nursing education programs, but there's a lot of room yet for improvement. And they quote a study that estimated the time in the curriculum, and this would be the Bachelor of Science in Nursing curriculum, devoted to LGBTQ health. The mean was 2 hours in the whole curriculum, with a range of 0 to 17 hours, with 17% of the reporting higher ed organizations indicating they had no content whatsoever. So we can go with the idea that there is a general lack of knowledge among nurses for LGBTQ practice. So the authors go through in their chapters some terminology and health concerns to form a basis for when we get to what can we do with this information that we know in promoting health among the population. The classification of people into sexual identities and gender identity really started with classification systems in the late 1800s, but were considered mostly prior to that behaviors rather than defining characteristics. And the new labeling of sexual and gender identities had some positive and some negative consequences. As people who identified among the LGBTQ plus community saw themselves in the new labeling, it gave some cohesion and affirmation, if you will, and led to a rise in culture. And that we see as a good thing. The negative came from the stigmatization by religion, healthcare, and legal systems that these people had a defect, they had a diagnosable illness, and also were sinners, and shamed and so forth. So as people who were identify among the LGBTQ community became more visible, there was some pushback by people who were threatened by that for whatever reason. So people who were of that identity and acted on their sexual identity were categorized as having mental disorders for quite for a long time. The DSMs in 1952 included homosexuality as a mental disorder, a neuroses of sorts, and they called it gender identity disorder and so forth. That led to a reaction among the community against it, and in the 70s and 80s, in particular, with the gay liberation movement, as it's called in the United States, there was pressure placed on the uh, healthcare community to revise that perspective. And that was combined with the emerging HIV/AIDS epidemic, which really came in the late 70s, mid 80s, when there was, I don't think there's anybody here old enough to remember, but I mean, there was ACT UP, and there was a huge social movement that was uh, occurring, which led to changes in legislation, but also led to some harassment and invalidation. So we have the, emergence of these people in their own identity and expressing that and finding uh, no longer the need to remain hidden, uh, which was positive for their mental health. But at the same time, it triggered a negative reaction from other parts of society uh, in the form of harassment and violence. And it wasn't until about 1973 that the DSM actually removed uh, homosexuality in particular, and that could be either gay or lesbian, as a mental disorder. It was taken out of the DSM. And there was absolutely no data to support it. It was all there out of bias. There was no data for it in the past. So that was at least a major movement for healthcare and how we help people who identify in the LGBTQ plus community by no longer classifying it as a mental disorder. That would mean something that we would have to treat. Based on their assumption that nurses don't know a whole lot about LGBTQ community or its health needs, they go through some terminology, which are in the following slides. And it is important to use correct and considerate terminology when we are interacting with and talking about and planning for healthcare for people who identify in the LGBTQ plus community. One is sexual orientation, and that means patterns of attraction, behavior, identity related to one's preferred sexual or romantic partners. That could include fantasies, behaviors, and identity components. Sexual preference is a term to be avoided, and the problem with that term is that it isn't something someone prefers. The concept is it isn't like you make a choice, like I'm going to buy a red car instead of a blue car. That would be a preferential thing. It's not at all a matter of preference. Sexual identity talks about how someone sees themselves and how they, when they are willing and able to be fully open about um, their self awareness as it relates to sex, um, they identify as perhaps one of the terms of the LGBTQ, so forth, here, shown on this slide. Uh, and there's no definitive answer to the question of can that transition over time? Do people move back and forth? But basically, 3% of the population with genetic or biological differences that put their bodies somewhere between the categories of male and female, or these people describe themselves in a number of different ways. But what we need to be aware of is that it is not a two option, two kind of thing in terms of male female. That there is a range of ways people think about themselves, identify, and think, and we should have very special considerations when we are working with children who have disorder of sexual development of any type, to not force them into a predetermined category, because these categories really aren't based in anything other than um, than bias. Really, there is no um, particular way to prove that there are categories. They are just described, and we need to remain open to how somebody wants to describe it for themselves, and resist the urge to shape them into something we think would be more acceptable or more functional for them. So terms related to sex and gender, defining gender and gender identity. People who identify as female and are born female would say, I'm a cisgender female. People who are born with male secondary sex characteristics, sex organs and so forth, and never really attach to that and identify as another type of person, perhaps of a female or something blend of that, would be considered transgendered. And the process of righting that misalignment is called transition. And it is certainly a very socially charged issue for us. And these people, we know, take a lot of abuse, verbal, sometimes physical violence, as a result of not fitting into a more traditional categorization of their sexual identity. Other terms related to the stigma: homophobia, biphobia, transphobia, which in the Greek, of course, mean fear. It's more hating than fearing. Heterosexism or heteronormativity, something we all fall into. I think the heteronormal way of speaking happens so naturally that it's very hard. It requires a lot of attention to avoiding heteronormative discussion when we're speaking to patients. They go on to talk about gender normativity, the revealing of identities, but the big things here are minority stress. Those are not just certainly this minority, the LGBTQ plus minority, but we are learning a great deal more about the impacts of minority stress if you're an ethnic minority or religious minority. Anything that marginalizes you, puts you on the edge of the central part of the culture in which you're living, creates an enormous amount of stress, both internal and external. And that leads us into the discussion about microaggressions. These are acts, speaking, language, actions that people who are not in the margin may commit without the intention of harm, but they are harmful. That's a microaggression. And that leads us into the discussion about the health disparities among the LGBTQ population. And there are clear models now describing the relationship between stigma, minority stress, and illness. It is played out most vividly to us, I think, in terms of mental health and suicide risks. And there's data in the chapter about the relative prevalence of suicide, depression, substance abuse, other behavioral health issues among this population in comparison to hetero populations. One of the things in particular that why this particular population suffers so greatly around the minority stress, it relates to this last bullet point, effects of family and social rejection. Let's say we're talking about a racial minority instead of an LGBTQ minority situation. If you are in the minority race and you are certainly having minority stress, generally speaking, and we have to think about this in aggregate, not on an individual's basis, because everybody's own individual story is their story, but in general, you're probably going to have some kind of a family structure that has the similar or same characteristics as you. And so you have your family, however you define it, but probably your biological family, your nuclear family, is a safe place for you to go. when the rest of the world seems like they're attacking you. But for people in LGBTQ, many people, that part, that one safe space where others can harbor for, support and feeling loved is gone. They don't have it. They are rejected, and so the family unit that normally is the place where in society people go for feeling connected and having support and being loved and accepted, they're deprived of that. In fact, they're people that, quote, should love them are demanding that they do violence to themselves and to be someone other than whom they are in order to be more acceptable in the eyes of the family and society at large. So they don't have that safe space that most people in other minority categories, ethnicity, race, and so on and so forth, can find in their nuclear family unit. It's not available to the people. Oftentimes, this is not always true, of course, thank God, but many times not available to people in the LGBTQ community. So the pain that people feel from that kind of behavior and not having the connection, the attachment to their family causes such intense pain that they're led to using chemicals to numb the pain, and they get into substance abuse at a much higher rate than others. The other thing that will happen is they will find their family, if you will, within the community, and that may be wonderful or that might be really hazardous. It just depends on what relationships they develop. Healthcare access and quality of care is a big thing for people with poverty, LGBTQ plus people, and in healthcare, in our own environment of healthcare, lots of micro assaults are reported, and insults and micro invalidations. Part of it around our heteronormative language and assumptions, and others more just overt. So the recommendations that come from the evidence says we need systems change. Patient hypervigilance in creating a sense of safety, the LGBTQ content, integration into nursing education, and on an individual basis, the authors call upon all of us who are nurses to use cultural humility, and they offer the 4 suggestions of examining your own bias, being educated on LGBTQ health issues and social issues, knowledge of local resources for LGBTQ people, and being an ally or advocate for this community. The second chapter this week is chapter 21, which deals with substance use. The use of psychoactive substances and behaviors associated with it occurs along a continuum of use, abuse, dependence, and addiction. While the term misuse is often used interchangeably with abuse, it is important to differentiate between the two. Misuse refers to improper use of medications when seeking therapeutic results. Abuse is repeated and willful substance use for the purpose of pleasure, euphoria, and ecstasy. The appropriate term to be used in the continuum is abuse. ASAM, which is the American Society of Addiction Medicine, defines addiction as a primary chronic disease of brain reward, motivation, memory, and related circuitry. This disease is particularly concerning because disability and death can happen at any time along the continuum. In fact, drug poisoning, more commonly known as overdose, is currently identified as the leading cause of injury-related accidental death. The prevalence of use in the United States is high. The authors quote a Census Bureau report from 2019 that approximately 328 million people were living in the United States. And the Substance Abuse and Mental Health Services Administration, abbreviated SAMHSA, does an annual survey, and they ask individuals who are 12 years old or older about prior month and lifetime experiences. According to the data from their 2018 survey of the 327 million living in the US, about 165 million of them, 12 and older, had used some type of substance, that could be tobacco, alcohol, or illicit drugs, in the preceding month. The chapter goes on to be more specific about different types of use and whether what agents are used, is that alcohol or cigarettes or opiates and so forth. And I think we can summarize it by saying that the use is very prevalent. SBIRT, screening, brief intervention, and referral to treatment, is a standard used across our industry for identifying and intervening in substance use problems. Advanced practice nurses have a role in the use of SBIRT and the research on the use of SBIRT in various client populations and healthcare settings to help build the body of evidence that we need to have informed practice. So how big is the problem? Well, what about the costs? 20 years ago, in 2004, the Surgeon General's report estimated a cost to the United States of $559 billion a year for drug abuse and addiction related to alcohol, tobacco, and other drugs. That cost includes the costs for health care, lost productivity, crime, incarceration, and the enforcement of laws related to getting, having, and using drugs. The amount from then has risen to $740 billion a year, which was reported in 2017. The societal costs, calculated for prescription opioid abuse alone, were $11 billion in 2001, which then rose fivefold to $55.7 billion in 2007. And the trend line continues up. It's on the rise too, reported in 2010 to be 16,000 deaths. But the number, unfortunately, has really risen since then. When calculated by deaths per 100,000 of the population, the rate rose from 12.3 in 2010 to 16.3 in 2015. The increase in death rates in part has been attributed to the introduction of synthetic opioids like fentanyl into the stream of substances that are available for abuse, not legally, but available. These semi-synthetic and synthetic opioids have such a very narrow margin of safety that people overdose on them very easily, more so than the natural opioids, codeine and heroin, morphine. As the disease of substance use disorder has evolved, the approach to it has changed from, in the 2 decades ago, that time frame, the focus was on alcohol and tobacco, and both those substances create a tremendous amount of cost and deaths. Tobacco alone has been attributed for causing 480,000 deaths and related to 300 billion in smoking-related illness. That was in 2018, each year in the United States. But with the newer semi-synthetic opioids entering with their very, very hazardous profile in the general use group of substances, of psychoactive substances, a lot of the focus has been on the introduction of these agents, many of them manufactured outside the United States and brought illegally into the country and sold in large amounts and readily available. And these are getting a tremendous amount of attention. The risks are grossly underestimated in surveys of people in the adolescent and early adult age groups. These are just some of the drugs that we're talking about in the new psychotropic substances and synthetics. For some of them, there's no current drug laws to govern their sale. Um, we still see acute toxicity, uh, and uh, and some of them, like the cannabinoids, when they are produced in their synthetic form, have so much higher potency than the naturally occurring cannabinoids. That'd be THC found in marijuana and hashish and that sort of thing. These new cannabinoids just are much, much more potent and have really quite devastating effects on the brain, uh, which includes severe anxiety, agitation, difficulty in clear thinking, nausea, vomiting, high blood pressure, seizures, and so forth, delusions, paranoia, and incidents of violence and acute psychosis have also occurred. The hallucinogens have also seen a transition in what's available uh, for misuse, and the old hallucinogens like LSD and dissociatives, PCP, um, have transitioned into newer agents that are more potent. We're seeing a lot of use of ketamine, a dissociative anesthetic, which is meant for use mostly in animals, also used in humans, but has some pretty severe effects. And then there's in these designer or club drugs like G and ecstasy and that sort of thing, some new, more potent, more dangerous substances coming. They refer to this group of drugs called N-bomb, which is a form of a drug very much like MDMA, but it is actually based on phenylethylamine, and that is both similar to amphetamine and mescaline. The new bomb drugs are reported to be very dangerous because of their potency, and users need only a few grains to feel the effect. They get serotonin toxicity, hyperthermia, and they are becoming a ever higher public health concern because they're readily available online and frequently are presented as legal LSD substitutes. These substances carries personal as well as societal cost. Personal cost is that your functionality, your ability to cope with life, and to attend to the things that we need to do for daily living, like raising kids and keeping a job, having money for food and shelter, are significantly undermined. And when the more traditional ways of making money for the basic necessities of life start to fail because of because the person who's using the substances is so impaired, they may turn to other things to make money, which are very hazardous. So there's a very personal cost. And also the societal cost is expected to just continue to grow. And we've talked about the numbers, but the costs come from kind of different categories. There's the category of lost production and productivity in society, law enforcement costs, and health treatment costs, and it's multi-generational. So when a parent becomes impaired to the point that they can no longer satisfactorily parent the offspring, then you see the cost then is not just in the year or in the moment, but is projected forward and compounds, so that the costs really get to be quite staggering. One of the most important things we can do in health promotion is that programs can't focus only on educating public about prevention, intervention, and treatment for the disease of addiction, but we have to present the information in a manner that will decrease or eliminate the stigma. We want people who are suffering in substance use disorder to feel safe to make themselves known and to get treatment. And stigma will prevent that from happening. And for this reason, health promotion professionals need to understand the disease and the evidence-based best practice for treating substance dependence. The goal in Healthy People 2020 for substance use is to reduce substance abuse to protect the health, safety, and quality of life for all, and to reduce the use of tobacco, to reduce illness, disability, death related to tobacco, as well as secondhand smoke. As advanced practice nurses, we can look to national guidelines. We may now want to go back now in 2023 to 2001 Institute of Medicine report, but SAMHSA and the National Institute on Drug Abuse are organizations that have current evidence-based guidelines for identification, early intervention, treatment, and prevention of substance use disorder. So the key points of this chapter are: substance misuse refers to the improper use of medications when seeking therapeutic results, whereas abuse is repeated and willful substance use for the purpose of pleasure, euphoria, and ecstasies. Nurses and healthcare providers should be familiar with SBIRT framework to intervene with clients seeking help with substance abuse. Addiction to heroin and prescription opiates is a major public health issue leading to significant loss of life and financial cost to society. Research on MAT shows that many successfully overcome opioid addiction with a combination of pharmaceutical opioid replacement and psychological support. The national organizations, like SAMHSA, provide guidelines on best practices and treatment modalities for busy practitioners who see individuals suffering from addiction. There are also specialty certifications available for nurses or healthcare professionals who want to focus on caring for individuals who struggle with addiction. And that's it for this chapter.